right, so next we're going to generate solutions in question 4. Figure out what can I do, what's indicated or not indicated, what's going to address the priority problem or worsen that problem. And remember, this depends on your understanding of the content, because I would treat dehydration, or I would treat impaired perfusion related to dehydration with IV fluids. But if I tried to treat impaired perfusion from heart failure with IV fluids, I would overload my patient. So you really have to understand why you're doing each thing and seeing each thing. So let's look at that here. In question 4, we've given a bolus of IV fluids, transferring to the ICU. Now for each of these potential orders, click to specify whether the order is anticipated or not anticipated in the care of the client. And so let's take these one at a time and obtain blood cultures. So we get blood cultures when we're worried about what problem? When we're trying to diagnose a very specific problem. And it's another problem that can cause signs of low perfusion if it ends in shock. If we're culturing anything, it's to see if there are organisms in it, right? So if I'm collecting blood cultures, it's because I'm looking to see if this patient has sepsis. And Oman says, no, I don't need to know. 1, it's not anticipated. Yes, you're correct. We don't want to do wasteful diagnostic studies. This would waste time. We don't have any reason to give this patient blood cultures. We don't have a fever. And then the only sign of infection that we might have is this high white blood cell count, but that can happen with inflammation too. And we've got obvious inflammation in this patient. Good. Monitor mental status hourly. Yes, right? We've got an abnormal mental status. We're told this patient is lethargic, confused, and when we're giving IV fluids, we can cause some rapid shifts in fluid shifts, including with the brain. So when you're treating DKA, you're watching for signs of cerebral edema. So they come in and they're lethargic, and our treatment is going to be putting them at risk for cerebral edema. So it's very important to monitor their mental status. Now, am I going to feed this patient right now? Do I want to initiate a carb-controlled diet? You guys said 2 is anticipated. You guys are excited. I love all caps from Peter and Cadena. All right, so remember, if I feed this patient, not only is he nauseous, but I'm trying to really tightly control his blood sugar. So yes, you guys are correct to say no. I might eventually do this, but this patient is not ready to eat. That's going to set us back by raising his blood sugar and making him more nauseous. Continuous cardiac monitoring. Yes, we talked about how our treatment is going to be lowering the potassium level. The potassium level was already elevated when he came in. And so anybody who has an electrolyte imbalance with potassium, you want to make sure that they are on the cardiac monitor. So good job. Monitor INO. Yes, we've got a dehydrated patient with poor skin turgor, likely low urine output. We've got tachycardia. So we've got signs of dehydration, and we're giving an IV fluid bolus. So our fluid balance is a major thing that we're addressing here, and we want to do this. Monitor the capillary blood glucose hourly. Yes, we want to check the blood sugar every hour and make sure not only that we're giving them enough insulin, but almost more importantly, we don't want to give them too much insulin and drop their blood sugar. So that's the other big thing we're monitoring when we're treating DKA. It's their mental status and obviously their INO and blood sugar. Those are our kind of big 3. So that's correct. Do I want to collect the serum potassium every 2 hours? Yes, just like we're worried about the glucose going too low, we're worried about the potassium going too low as we give insulin to push it into the cells. So we're watching that and making sure that we're not causing hypokalemia. Then a continuous IV insulin infusion pump. Yes, so we're going to give continuous insulin. You never hang insulin, heparin, potassium, or any other high-risk drug to gravity. These always go on an electronic infusion pump. So this is correct as well. Then continue IV normal saline at 500 mils an hour for the next 2 hours. Yes, this patient needs a lot of fluids. They become very dehydrated from this. So we've given an IV fluid bolus, and we need to continue giving IV fluids. So, all right, this is a lot of work. This patient needs a lot of things, and this is a very critically ill patient with circulation and metabolic issues. So we don't need to worry about infection. We need to keep them in PO. And then while we're giving IV fluids and insulin, we're watching their mental status, their heart rhythm, their INO, glucose, and potassium. So this is a big monitoring patient. And we're correct.